Hello, everyone. I'm M Oddo from Lausanne, Switzerland. Welcome everyone to this session on traumatic brain injury. I'm going to discuss about oxygen and CO2 targets. Thanks ISICEM for the invitation, for setting this up as a virtual conference, and thank you all for attending this session. I don't have any particular disclosures related to this presentation, and I would start the presentation with a summary of definition. And on the left part of the screen, you see what we define as hypoxia, which is defined by low brain tissue oxygen. So to have it, you have to measure brain tissue oxygen. And what we are going to discuss here mostly is actually arterial PO2. So what is the optimal amount of PaO2? And the definition here is hypoxemia, where we are discussing of low blood oxygen, hyperoxia if it's a high fraction of inspiration of oxygen, and hyperoxemia if you have high blood oxygen, so it's PaO2. I think these definitions are very important because you have a mixture of several things in the literature. And oxygen, when you look at cerebral blood flow, one of the rationale of the pathophysiological rationale, what you see is that we want to have optimal PaO2, first of all, because you want to avoid brain hypoxia, which the PO2 and PbO2 are very highly related. And secondly, because if you have hypoxemia, this will cause vasodilation, and in patients at risk of intracranial hypertension, this will cause, of course, an increase in intracranial pressure. On the right part of the screen, you have the definitions which are more clear of hypercapnia, which is high PCO2, and hypocapnia. And of course, the PaCO2, the CO2, is a potent driver of blood flow. So when you have a hypercapnia, you have a vasodilation, which you don't want if you have an issue with ICP. And by reducing PCO2 with hypocapnia and moderate hyperventilation, you can vasoconstrict and therefore reduce intracranial pressure. So this is a very important slide. And the question is, what are the optimal targets? Now, I summarize what we can say based on the available literature in terms of hypoxia, which is based on the targets for brain tissue oxygen, hypoxemia, probably, and I would say probably, you have to put the PO2 rather to the right hand side here. So maybe it's 80, some say 80 to 100. So probably higher than in the general ICU population. And then the definition of hyperoxia above 60% and hyperoxemia above 150, or some other report 300. And for hypercapnia, in the general population is 45 for hypercapnia and less than 35 for hypocapnia. But we will see that in brain injured patients, probably the target for hypercapnia is lower, and the same with hypocapnia. Right, so what we can say based on the review of clinical data? First of all, there's a lot of data showing that hyperoxia may be bad because it increases reperfusion injury and for other reasons. But if you specifically look at the literature in patients with acute brain injury, with traumatic brain injury, which is the topic of this presentation, TBI, you would see that retrospective data analysis suggests that PaO2 above 300 may be associated with worse outcome. But again, these are retrospective data analysis and association. Other retrospective data analysis using large amount of data, these are from Australia and New Zealand, more than 24,000 patients. And what they show is actually that the adjusted odds ratio for a poor recovery after traumatic brain injury is for hypoxia below 60 and for hyperoxia, but again with a threshold, a target above 300. So it looks like the 300 is something that you really want to avoid, and definitely hypoxia, what we know already, is bad for the brain. This is another study which actually, this is an analysis of a randomized control study on pharmacological intervention in TBI patients. And they looked at this prospective data analysis and they looked back at the thresholds, the target of PaO2, and they tried and adjusting for several outcome predictors to try and see whether there was a threshold that was associated with worse functional outcome or, on the contrary, better functional outcome. And this study is pretty much interesting and I would say actually surprising, because what they found is that a threshold of, let's call it moderate hyperoxemia, so PaO2 in between 150 and 200, moderate hyperoxemia, so not exceeding FiO2 above 60, but raising PaO2 to in between 150 to 200, was actually associated after adjustment with a better functional outcome. And these are prospective data based on a randomized control study. This is using brain physiology, so using brain tissue oxygen and cerebral microdialysis, and see whether hyperoxemia, actually here you see that is hyperoxia, so true hyperoxia, raising FiO2 to a very high level, which then in a normal lung will translate in very high levels of PaO2. So this is hyperoxia and hyperoxemia. And if you look at these studies, I would point out on those time points, because you see that this is short hyperoxic intervention. So it's in between 3-6 hours. There is just one study where they use 24 hours. It's basically mostly in the early phase of injury within 48 hours. And they looked at the effect on cerebral oxidative metabolism using lactate to pyruvate ratio and brain oxygen. Well, obviously, as I told you before, there is a very close relationship between PaO2 and PbTO2. So you raise FiO2, you raise PaO2 because the lung is normal and brain oxygen goes up. But what I found very interesting here in this summary is that in most studies, short time hyperoxia was actually associated either with no major disturbance in cerebral oxidative metabolism, or actually in reduced, so in an improvement in cerebral oxidative metabolism as manifested by a reduction in the level of lactate to pyruvate ratio. So basically a benefit on the tissue. Now, whether PCO2 is a very big issue, there is an ongoing consensus on ventilation, and these took the authors a lot of time to determine whether there is actually a consensus. And I will not discuss about the consensus, but I will discuss about pathophysiology and data. And the pathophysiology is clear. Well, if you have elevated ICP, you reduce CO2. What you have is that you reduce volume because you vasoconstrict, and reduce ICP, left part of the screen. But the problem here is that with vasoconstriction, the risk is that if you reduce too much, and if you go below 30, so from 35 to 25, well, the risk of true ischemia is relatively high. So obviously, based on this study, you don't want to have an aggressive intervention, so aggressive hyperventilation, defined as a PCO2 below 25. What you see in these two studies is that if you are more gentle, intervention is PCO2 around 30 to 35, you actually have a benefit because you don't have ischemia, and you see that there is uh, basically a balance in terms of metabolism. So of course, if you go too low, you can endanger the tissue and the flow, but in general, there is a good balance. So I think that these data show that if you stay above 30, it looks as it's fine. A way to measure this interaction between CO2 and flow is to monitor brain tissue oxygen. And what we often see is that if you go low with CO2, this is parallel with a reduction in brain tissue oxygen. So this is a way, by using brain tissue oxygen, to adjust optimal CO2 level in terms of ICP and brain tissue oxygen. Associations showing that if you stay in between 30 and 49 in patients with traumatic brain injury intubated, basically you have actually an odds ratio in favor of a good outcome. So if you are lower or higher, there is an odds ratio which is unfavorable in terms of good outcomes. So staying in between 30 and 49 looks as it is quite okay. And again, when you look at practices, we mostly in general use, depending on whether there is or not a problem with ICP, a PCO2, which is around 35, in between 30 and 40. And this just 1 minute to say that the famous Mosela study, which is the only randomized intervention, found that there was actually a better outcome with the control group versus aggressive hyperventilation. Remind that the control group was a PCO2 of 30 and the aggressive hyperventilation was 25. So to summarize, this is my final slide. Avoid hypoxemia, avoid hyperoxemia. Maybe we should use a more liberal oxygen therapy in patients with brain injury, but this is not based on firm evidence. And as for PCO2 targets, strict normocapnia, you can use hypocapnia when ICP is high, and potentially combine monitor of blood flow, which can be transcranial Doppler or brain tissue oxygen monitoring. Thank you.